Hi.
Hi.
Dr. Asan.
Yes.
I have a few questions to ask you.
Okay.
I just wanted to ask you, what is Therapy Impasse exactly?
Sure. Therapy impasse is a situation, more or less, that is a label for a particular type of situation that therapists mostly experience. And it does happen with every therapist. Research shows that whether you are a beginning trainee to a licensed clinician, a seasoned therapist with many, many years of experience, all therapists experience that type of situation. So we call that therapy impasse, but it's called an impasse for a reason, for a purpose. The impasse indicates a sense of being stuck. It's an impasse. It's almost like a bottleneck. You can't move forward or backward. You're stuck. You don't know what to do in this type of situation. And it has to do with therapy. That's why we call it therapy impasse. However, that is more of a new, if you will, or novel word or phrase that is being used, although it has been in the literature for the past 40 years. Different scholars and practitioners and writers and clinicians, they have written about it, but it hasn't really picked up in the field to a greater extent. What the average therapist knows about therapy impasse are the symptoms. The symptoms are things like compassion fatigue, resistance, client resistance, burnout, detachment, not liking your client anymore, feeling less empathy toward the client, wanting to terminate this type of client, if you will, and also a lot of, if you will, labeling, meaning that we get a lot of reactions from therapists who say, oh my goodness, I have this bipolar, if you will, or XYZ borderline, or whatever labels that they use, type of a client that drives me crazy, more or less. That's the type of experience. And they may not really publicly attest to it, but privately, if you talk to them, you get this type of heightened sensation of anxiety, that they don't like that type of situation anymore. They don't enjoy the therapy. They don't enjoy doing therapy with a client. They used to do therapy and enjoy doing therapy. And it can occur from the very beginning of the session with, let's say, more general, with the type of population that a person may not like to work with. For instance, for some therapists, it may be, let's say, addiction. They don't want to work with addicted individuals, but because they're working at a specific site and they're assigned to an addicted person, then suddenly they have this awful reaction to it. Or it can happen in the midst of therapeutic relationships. So after a few sessions, they suddenly realize the client is not making any progress, I'm not making progress, and there's no hope for this therapeutic relationship. So they tend to want to terminate, to maybe hasten through the therapeutic process and just bring it to a close. And sometimes they get disillusioned and disappointed that nothing is working. So as a result, it is the therapist who feels inadequate and sometimes even helpless. So they have this heightened anxiety, they have this emotional reaction, and on top of it also they start doubting their profession, they start doubting themselves, and they really get upset and agitated about the situation to the point that they would love to terminate. And that termination most likely leads to what we know as a rupture in the therapeutic alliance. So now the therapeutic alliance is torn apart. The therapist is not feeling very effective in that relationship, and it's also mostly not a good feeling for the clients. In fact, there is a lot of research on that shows a lot of clients, they didn't like their therapist, it didn't work out, they had to terminate, and so forth. And so more or less the therapy impasse, if it is not contained, if it is not processed, leads to dissatisfaction on both ends. It leads to injury, psychological injury on both ends. And there are very good books that have been written about it. They come from psychoanalytic background and history, such as Tansey and Burke. They wrote about the process from projective identification to greater empathy. That has to do a lot with countertransference and negative countertransference, destructive countertransference. And also Susan Elkind, she wrote about all the detrimental effects of therapy impasses on the therapists themselves that can lead to these long-lasting, if you will, nightmares, that therapists themselves experience. So there has been good research on it, but nobody has been following through. Nobody has been really putting effort in understanding it better, coming up with more of a common terminology so therapists can come to terms, have a consensus, talk about the same thing, no standardized way of talking about this, at least amongst therapists, let alone getting a clinical training in their counseling or clinical or even academic or industrial organizational training. None of that is really addressing therapy impasse on those difficult situations. So therapists, more or less, they are left with postgraduate continuing education only, personal therapy and supervision, whether it is peer supervision or a consultation that would be helpful to them in these type of particular difficult situations. But it also makes them dependent on this particular auxiliary help, rather than like any other type of skill that we learn during our clinical training, where a therapist learns certain methods and models and techniques that they take with them. They are not completely dependent on others. They become interdependent or independent. They rely on themselves, on their own techniques to deal with the situation. So that's why it is important to recognize therapy impasse, label it correctly, know where it comes from, know its sources, know how it happens, and what the role of a therapist is within the therapy impasse. And it is a very significant, vital component of the therapeutic profession. We are in this as professionals and we want to help, but how can we help if we are stuck and we didn't learn about it in our clinical training, and we are only relying on sporadic, if you will, auxiliary help to deal with these situations? We cannot really be that effective. So that's why we started talking about therapy impasse.
Okay, and I heard you mention a standardized clinical training. Is therapy impasse attached to any theory, or you said it's just kind of a standard training institute?
Therapy impasse, because it hasn't been explored enough, there are only a few models that are out there, basically really just one model, if you will, that comes from the psychodynamic perspective. And unfortunately, the creators of this model did not go any further in developing it even more and incorporating it into a training model and so forth. So when I came across a therapy impasse, I learned about the model, but it wasn't enough for me to really deal with the therapeutic impasse. So what I had to do is really put about 2 years of my own time, and basically I made it the topic of my dissertation, and did a few studies, a qualitative and quantitative study about it to understand it better. And once I was able to understand it and deal with it, I was actually really able to take that model and expand it and include what else, other type of resources that we have in the field that were not available when the model was developed. When it was developed, it was in the late 80s, which is almost 30 years ago, and they only had this psychodynamic, psychoanalytic aspect. But over the last 30 plus years, since the model has been developed, we know that within the therapeutic relationship there is a lot more going on, such as attachment, issues of attachment theory, attachment styles. There are primary wounds. There is this wounded healer paradigm that highlights what's going on between the therapist and the client, as both are wounded people as well as healers themselves. There is a neurobiological component in terms of what we now know as more or less hemispheric integration, that we need to integrate both emotions and thoughts, both right brain and left brain, in order to present with more of a holistic experience, paying attention to the here and now, so the mindfulness techniques, relaxation techniques, meditation techniques that are very, very useful, using the person of the therapist in the therapeutic relationship, just like from a systemic perspective. So now we have a model that has been based on that original psychodynamic model, but then takes into account all these other aspects of therapeutic relationship. So we have taken that and developed it into a training model that is now being taught at our institute. So we had to create an institute around this model to really get the training out.
Okay, thank you.